then in this position, he says that's an AC joint problem. The problem with the test is nobody's been able to get the same results as Steve, because he was basically 92% accurate. In my hands, all the SLAP tests, including the one that I developed that I was sure was absolutely on the money, all of them are about 65%. So you use them in combination, and you use the history. That's how I use it. And then the other, Whipple's test is resisted elevation in that position, which he felt isolated the anterior portion of the supraspinatus. And then Speed's test, by definition, is the arm is brought into forward flexion. It's resisted elevation, is not painful, but as you supinate and externally rotate the humerus, it is painful because you're putting the biceps under stretch. I do Speeds, but I also do it out here because the most classic symptom I get on patients in whom I diagnose biceps tendonitis is it hurts like hell when I reach into the back seat of the car. So I just try to reproduce that. So I try to make my test as functional as possible. I just listen to the patient lead me to the exam.
I don't know if I can accurately describe my question, but my question tends to question the difference between examining younger patients versus older patients and their contractures or their capsular fibrosis. And older patients, when they have an injury, they tend to not use their shoulder, and they develop what I would consider capsular contractures. And my question is this a scapular dysfunction or is it capsular contraction? What do you think about older patients?
I think that the nice thing that the good Lord does for us is he gives us two shoulders to examine. So you use one as a control for the other. So in my older patients, I'll talk about symmetrical range of motion and compare one to the other. So we know with age there is a capsular contracture. And so you do lose motion primarily in forward flexion, first foot in forward flexion and also in internal rotation, and the other is secondary to that. So I compare sides. I'll tell you one, as long as we're talking about it, I'll use Nathan as an example. One of the early tests that I use for adhesive capsulitis is loss of the sulcus. So if you have a patient that's in her 50s, first of all, she's got shoulder pain and she's in her 50s, that should be the first thing on your mind. But the test that I use is a sulcus sign in abduction. And what I do is, actually I sit on the table with the patient the way I am now, just relax your arm. I just cradle the arm against my chest, and I just push the humeral head down. And I describe to the patient, are you feeling the ball drop down like it's dropping into a hammock? And one of the first signs of adhesive capsulitis is they lose that because the inferior ligament starts to get tight and you lose that. So that's the way I look at it. That's my capsule exam on older people.
A lot of these young athletes complain of pain at the back of the shoulder here. That's what they say, they have pain here. How do you interpret that?
How do I interpret that? That usually to me is scapular dyskinesis. And I didn't ask Nathan to point to where he hurts. And actually, I should have done that in the very beginning. Tell me where your shoulder hurts. Okay, so he's got an impingement type of pain. And then Dad told me that you have pain that goes over the back. Is that? Okay. So it's not uncommon for people to present with that. And that, to me, that just makes me think more about the scapula. But I think about the scapula no matter what. I mean, that's my bias.
You dream about the scapula, I know, yeah.
Only my wife's.
The history was a single event, but is there aspects of the way these young guys train that lead to the dyskinesis, or was the single event the factor?
That single event when he felt the pop? No, I think that was a symptom. I think the problem was probably his throwing mechanics, his kinetic chain failure that caused more stress on the proximal humeral epiphysis. That's the way I look at Little League shoulder, because that's really the way he presented, was with an acute Little League shoulder. And Giovanni, I mean, was incredible, the way he spoke about victim and culprit. The shoulder is usually not the culprit. If you look at the glenohumeral joint, it's usually the victim.
I'd like to discuss treatment now. example, if you had a patient with capsular, can you hear me?
I'm having trouble. Go ahead.
If you had a patient with capsular contracture, and the older patient I'm talking about now, would you treat that first before you went into treating the scapular problems?
Would I?
If you had a patient with capsular contractures,
Yeah.
And they also had the scapular dyskinesis, which one would you direct your treatment to first? Can you correct the scapular problems without addressing the capsular problems?
No. You can't have a significant scapular contracture and normal scapular kinematics. You know, the way I look at, this is another whole lecture, but the way I look at scapular dyskinesis is as proximally based or distally based. Is there something happening at the glenohumeral joint or distal to that that's causing a kickback inhibition of the stratus anterior and lower trap? Very, very common. If you have somebody with, statistically, if you look at people with impingement, rotator cuff tear, and instability, depending on what you read in the literature, anywhere from 65 to 100% of those people have scapular dyskinesis, if you look at it. In my practice, it is virtually impossible to have a rotator cuff tear or instability without having scapular dyskinesis. So you've got to figure out what's the cause, what's the effect. And if it's a capsular contracture, you may just have, in an older patient, you may just have to buy that. If it's not an adhesive capsulitis where there's an inflammatory component that's causing a dysfunction, that may just be the patient. You're not going to stretch out the capsule in a 70-year-old patient.
Ben, can I say a thing regarding this question? In my practice, there is a different set, this patient with the standard patient when they have 50, 60 years old. I think that the soft tissue problem in this kind of patient, of course, is a cascade mechanism, is overload. In the other set of patient, it's not clear why they get capsulitis and why they get scar tissue. So in those patients, when they lose more than 25, 30 degrees of range of motion on all the planes, I emphasize during rehabilitation the stretching program is the key point. Because if they have contracted capsula, as I've shown in some video clips, they have also scapulothoracic dyskinesia. Because if the scapula and humerus doesn't work well, the scapulothoracic joint doesn't work well. So the first goal in this kind of rehabilitation in my practice is stretching program. Then I go on the core stability, scapulothoracic stability.
Do you ever do close manipulation?
Do you ever do manipulation?
No, I don't do manipulation. I have my physiotherapists that they teach stretching exercise like sleeper stretch, something like that, and the patient can do also by themselves.
No, I mean close manipulations under anesthesia.
Oh, it is very rare. I use very much intrathecal injection, 4 cc of water, physiologic water, and cortisone, 1 every 10 days, and the stretching program, and we have excellent results in this kind of patient.
Giovanni, you said you do intra-articular cortisone every 10 days?
Yes, 1 cc.
1 cc?
1 cc every 10 days with 4 cc of water into the glenohumeral joint.
Okay, why do you use water instead of xylocaine, let's say?
I don't use lidocaine because in literature there is some report about chondrolysis using anesthesia. Okay. And I like very much water because if the capsula is stiff, I think that with the water into the glenohumeral joint, I can facilitate the work of my physiotherapist because water keep the capsula much more softer.
And what would you, what limit would you put on the number of steroid injections that you
1
would
cc,
give?
1 cc.
How many times, though? You say every 10 days?
Every 10 days for 3 times. No
3
more.
times only?
Yes.
Okay.
10 days, 15 days, more or less this is the time. Well, we have excellent results in this kind of capsulitis. Also, when they are diabetics, I ask consult to the diabetic doctor, and if they allow me, we do cortisone injection into the joint. But with program of stretching, the results are great.
Okay, well, I think we're coming to the end of this session, and certainly want to thank Ben and Giovanni for a wonderful display of how you can spend an hour and a half in your examining room with one patient.